Hi, this is Brian Kim. I'm going to share with you case number 88 in the best way to do cataract surgery series. This is a patient with a dense cataract as well as intraoperative floppy iris syndrome. You're going to see a double chop, cross chop, mechanical fracturing techniques. I'm using the chopper to protect the iris from the phaco tip as I do the intraocular maneuvers, trying to manipulate the lens pieces, crushing the lens pieces by using mechanical fracturing forces rather than going after the pieces with the phaco tip. This reduces the risk of iris trauma, especially in the IFIS situation. I'm using a cotton tip to steady the eye and make a corneal mark to help me center Incisor-rhexis. Make my paracentesis incision first on the right side and then the left side, making sure it's flat to the iris plane. Get a nice shelf, which will allow me to achieve a self-sealing incision. I'm injecting some intracameral lidocaine as well as some intracameral epinephrine. And then I'm injecting some dispersive viscoelastic to flatten the anterior capsule as well as coat the corneal endothelium. I'll use that cannula to hold the eye still for my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, turn the eye towards me with the cannula, and then enter. Push a little bit more viscoelastic. And this is the puncture style rhexis. I go in with the teeth sideways. Going to go ahead and puncture the center. Pull downward towards me. With the teeth closed, I'm trying to redirect the tear, grabbing the right side of the tear to create a flap on the right side. Carefully going around, trying to use my corneal mark to guide the centration and size of the rhexis. Finish off the rhexis, burp some viscoelastic out of the eye. And this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down towards the nerve, get a nice wave, decompress on the left side, point the tip to the right side, pointing down, hooking the lens, and I'm able to spin the lens. Irrigate the surface of the cornea, adjust my sleeve. I'm making sure I expose the sleeve a little bit more with these dense lenses, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuchal material, placing the chopper around the lens contra-incisionally, pointing the phaco tip vertically sub-incisionally, separating the lens in half completely, that is the double chop, placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip, crushing and dividing the right heminucleus, that's the cross chop. Using some vacuum to lift the first quadrant up out of the bag, and then crushing it between the chopper and the phaco tip, and then emulsifying the lens pieces, using a little bit of vacuum, going around the lens piece with the chopper, lifting it up, and then grabbing it with some vacuum, and then crushing and emulsifying the lens piece. Again, using the chopper to get around the lens piece, lifting it up, and then grabbing it with a little bit of vacuum. I like to use the chopper to hook the lens piece up. It's just really a good habit, in my opinion, rather than going after pieces with the vacuum. Placing the chopper around the second quadrant, crushing it between the chopper and the phaco tip, separating the pieces, getting around the lens piece again, crushing it, and then emulsifying the lens pieces. I position the lens pieces on the phaco tip using a little bit of vacuum to hold it, and then crush it with the chopper. I'm going to turn the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally toward the phaco tip, positioning the phaco tip deep in the bag, dividing the lens in half between the third and fourth quadrant now, placing the chopper around that third quadrant, pulling it centrally toward the phaco tip, dividing that fragment in half as well, separating it, grabbing that fragment up with some vacuum, lifting it out of the bag, crushing it and sandwiching it between the chopper and the phaco tip, and then emulsifying the lens piece. Grabbing that piece with a little bit of vacuum and then crushing it and then emulsifying the lens piece. Placing the chopper around the lens piece, hooking it, pulling it up, crushing it against the phaco tip, and then emulsifying the lens piece again. Just keep doing the same thing over and over and over again. That maneuver is the reason why I'm able to use limited amounts of ultrasonic energy. There's a little bit of iris coming to the wound there. So I'm having to sweep the incision with my phaco tip and take the chopper out. I'm trying to put some more viscoelastic to coat the corneal endothelium and push that iris back because I noticed that the iris was not really behaving very well. So push the iris back with the viscoelastic. I'll try to remove this last quadrant, rotating it a little bit, getting around it with the chopper, pulling it towards the middle, crushing it against the phaco tip, manipulating that fragment with the phaco tip in the chopper, and then crushing it into smaller pieces, and then emulsifying it. I try to be mindful not to use any vacuum or ultrasonic energy near the iris. When I'm trying to manipulate the lens pieces, I'm not using any vacuum. If I was, I would be at risk of grabbing the iris. When I'm trying to position the lens piece, I'm trying to do that so I can crush the lens piece between the chopper and the phaco tip. And once the pieces are smaller, go ahead and emulsify the lens piece. This can be quite tedious in a dense lens, but these maneuvers are the reason why I'm able to use sparing amounts of ultrasonic energy. So I carefully remove that thickened epinucleal material. And then carefully take the chopper out. You can see the iris coming towards the incision. I go in with BSS and then decompress the chamber, turning the irrigation off, and then I come out with the phaco tip. I go in with the INA handpiece with irrigation off, and then sweep the paracentesis so that the iris is not incarcerated within the incision. I start subincisionally removing the cortical material very carefully. I'm trying to be mindful that I don't accidentally grab the iris when I do this. So I switch to polish mode first, And as I'm sweeping underneath the iris, if I find a little bit of cortex, I try to pull it up, and if it doesn't come all the way out, I'll switch to cortex mode. So that's one of the things you can do so you don't traumatize the iris too much. I switched to the polish mode early here, and I'm sweeping underneath the rhexis edge, and because the pupil's coming down, it's kind of a blind maneuver. But if I catch some cortical material, I can switch it to cortex mode pretty quickly with foot pedal control. I'm polishing not only under the rhexis edge, but also on the posterior capsule surface now. You can see it causes quite a bit of stria in the posterior capsule, which suggests there's some level of zonulopathy as well. I decide not to pulse in the subincisional space due to the floppy iris. I go ahead and push some cohesive viscoelastic to fill the bag very carefully and slowly. And then now I'm sweeping under the rhexis edge, under the left side, and then on the right side. This is a 3-piece lens, so I go ahead and widen my incision to accommodate that lens. I'm using the sweep to protect the iris subincisionally as I try to place the cartridge within the incision. Go ahead and push some more cohesive viscoelastic to fill the bag, and then I go ahead and deliver the leading haptic into the bag, making sure the bevel's facing to the left and it comes out flat. As the optic comes out, I rotate my hand counterclockwise about 90 degrees and then deliver the trailing haptic outside of the eye, and then I'm dialing it in with the Maltzman. Go in with the INA with irrigation off, go underneath the lens, removing the viscoelastic from within the bag. And then removing the viscoelastic from the anterior chamber. And then I'll hydrate my incisions. So you can see this patient had a floppy iris. It didn't really manifest as a floppy iris until kind of halfway through the phaco when I tried to take the chopper out, and you saw the incision was incarcerated with the iris tissue. So I was able to carefully use the phaco tip to push the iris away. Also used viscoelastic to push the iris away as well. And when I had to put the 3-piece lens in, I protected the iris as I was putting the injector into the eye, protected the iris subincisionally with the sweep. And the key is to always decompress the eye on the way out, because if you have high pressure in the eye and you come straight out, that high pressure differential is going to invite the iris to exit the incision. As you saw, I was able to use mechanical fracturing techniques, double chop and cross chop, to carefully and systematically disassemble this dense lens. And because I'm able to mechanically fracture the lens, I don't have to use ultrasonic energy or vacuum as I do this. And therefore, I don't have to employ any high vacuum. Therefore, there is less risk that I'm going to grasp the iris in a floppy iris situation. So I feel like it gives me a lot more control by using my instruments to crush the lens pieces into smaller pieces, and then just using high vacuum and ultrasonic energy in the central safe zone when I'm ready to emulsify the lens pieces. So I hope this was helpful to you, and I thank you for your attention.